In this video, I will be showing how I went about performing a phacoemulsification in a true posterior nodal cataract. After the usual incisions, I went ahead and placed HPMC within the anterior chamber. And with a cystitone, performed a rhexis. Please note that my rhexis is vertically oval in this case. I am specifically making it a vertically oval rhexis, keeping enough capsule horizontally. In the event, I would have to place a 3-piece lens within the sulcus. Once the rhexis is done, without performing any hydrodissection, I directly go and perform hydrodilineation. Using two sinskey hooks, one for fixation of the globe and with the other I try to manually delineate the central hardcore nucleus. I then go ahead and using my stop and chop parameters, I first sculpt in the center of the delineated nucleus. Once I have an adequate trench, I try to separate the two heminuclei, sometimes difficult, and here I am trying to use a little high vacuum to pick up these fragments, and there I have it. One heminucleus done, and then the other heminucleus. Now this epinucleus and cortex is not hydrodissected, and sometimes it can be very difficult to remove. So I have initially tried to use the Phaco probe itself, lower parameters, to sort of separate the epinucleus from the capsular membrane. Having been frustrated, I went ahead and did a slight hydrodissection, and that was a big mistake. As you can see, although I tried to do a limited hydrodissection, it has gone right across the central nodal area. Anyway, I still thought that the capsule was okay and went ahead and slowly tried to separate the epinucleus. I tried to do the epinucleus first before I go for the cortex. Tried to separate the epinucleus first from all sides in order to remove it almost en bloc. These are the cases which need extreme patience, and there is no way of hurrying these cases as I have done in this case. I am trying to get a hold of this epinucleus, and finally I do get it. I removed almost all the cortex, and there is a central rupture. So don't come out immediately. Fill the chamber with HPMC and slowly come out. There is a bit of cortex left, which I am trying to remove with dry aspiration using a Simcoe cannula. I am trying my best not to disturb the vitreous face. Sometimes it is very difficult to tell the difference between your HPMC and the vitreous. So don't be very aggressive at this stage. Keep putting HPMC and you can take out small bits and pieces of the cortex. Those small bits you see on the right are just air bubbles. You just leave them alone. Anyway, I go ahead and stain the central part just to make sure if there is any vitreous disturbance. again putting HPMC, I confirm that there is no vitreous disturbance. Once confirmed, I try to remove the other cortical matter with dry aspiration. Here I am just placing some adrenaline within the chamber and letting go of some of the HPMC as it has been a little bit over pressurized. Just trying to get a balance of how much I need to put and how much of HPMC I need to put. Once done, I then create space for placement of my 3-piece lens within the sulcus. You have to be very careful and ensure that the leading haptic goes over the anterior capsular rim. And do this step very slowly because these lenses tend to twist and turn in your hands. Once then done, I engage the optic and push the trailing haptic into the sulcus as well. And using bimanual and very low flow parameters, I also drop the bottle height. I slowly aspirate all the HPMC, both within the anterior chamber and also behind the eye oval. This part I do with extreme caution because I do not want this tear to increase. Before withdrawing, I try to hydrate the wounds so as to keep the chamber formed without any sudden decompression, and finally place some myocol within the chamber. Thank you for watching the video.